Okay, so I think we'll begin. Thank you so much, everyone, for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Today's program is a special collaboration between the Blum Center and Division of Rheumatology, Allergy, and Immunology. Before we get started, I just want to go over a few items with you all. Please note that today's program is being recorded for educational purposes. If you're interested in viewing the recording, you can visit our Blum Center website at massgeneral.org/Blum-Center. Please note everyone has been muted today so that we can hear our guest speakers. If you have any questions, please use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and the guest speakers will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. Okay, Dr. Katz, would you like to pull up your slides? So next, I would like to introduce you all to Dr. Guy Katz. Dr. Katz is a rheumatology fellow in the Division of Rheumatology, Allergy, and Immunology at Mass General Hospital. His research interests are in clinical epidemiology and treatment of immunoglobulin G4-related disease and vasculitis. He has a passion for medical education, and he enjoys caring for patients with all rheumatic diseases. He joins us today to give a talk on gout, so please join me in welcoming Dr. Katz.
Thank you very much for having me, and thank you everyone for joining. I hope to be able to shed some light on a very important topic if you ask my unbiased or my very biased opinion. So today we're going to talk about gout. I don't have any conflicts of interest to disclose for this talk. And I'd like to start with a little anecdote. If I may, I'll just read this out. A constant dull ache which grew more severe over a 2-hour period until it became quite severe, deep, and crushing. On this pain, irregular paroxysms of lancinating pain were superimposed. The joint was tensely distended and exquisitely tender. Systemic reaction after 3 hours was manifested by the sudden onset of pallor, which is being pale, diaphoresis, which is sweating, bradycardia, which is low heart rate, borborygmi, which is stomach churning, and syncope, which is fainting. 4 hours after injection, both subjects were prostrated, going to excruciating pain. So this, of course, is a description of someone's experience going through a gout attack. So the next time you hear someone talking about how someone's joint pain is just gout, think about this. It's an exquisitely painful condition. And actually, this description is from an article written from 1962 by two physicians who demonstrated what actually causes gout, which is tiny crystals of sodium urate. And the way they demonstrated that was that they injected themselves, their own knees, with the sodium urate to see what would happen. And they demonstrated that they developed this pain. Their intention was to see what happens after a couple of days of the injection, but within 4 hours, their pain was so excruciating that they couldn't take it anymore, and they had to start treatment for their gout. So today we're going to discuss gout. We're going to talk about what it is. We're also going to just briefly touch on what arthritis is, because it's a term that I think a lot of people use very often and is frequently misunderstood. We'll talk about what causes gout. We'll talk about who frequently gets gout and what the symptoms are of gout. Then we'll touch on how to diagnose gout and how we treat gout and prevent flares of gout. And then at the very end, we'll very briefly touch on an entity called pseudogout, which is related but different from gout. And I hope to leave time in the end for questions as well. So first, why do we care about gout? It's a very common disease. It's very frequently underestimated in terms of the effect that it has on people's lives. It's excruciatingly painful, as I mentioned before, and it can really be debilitating. But on the other hand, our treatments are extremely effective. If we treat early in particular, we can make an enormous impact on patients' lives. So what is gout? Gout is a disease in which there's deposition of a certain crystal called monosodium urate. When it crystallizes into the joints, it causes flares or attacks of painful joint inflammation. And that's what I described earlier. It can also deposit outside of the joints. And in particular, it can deposit in the soft tissues and cause what are called tophi, which is the plural version of tophus. And here we have pictures of both. So on the left, you'll see this joint right over here at the base of the great toe looks red and it's inflamed and it's swollen. The rest of the foot kind of looks swollen as well. So that is a painful gout attack. That's inflammation in the joint. And on the right side, you see this big lump over here. This is probably not painful actually in this patient's case, and probably he or she had it for many years at this point when this picture was taken. And that's a tophus. That's a large collection of those crystals that have formed over time. So as I mentioned, I wanted to talk about arthritis and what that actually means. So arthritis can kind of mean two different things, either osteoarthritis or inflammatory arthritis. And I don't want to spend too much time on this other than just to point out that there is a difference between the two. Osteoarthritis is what most people generally refer to as arthritis. So if you talk to an orthopedic surgeon, if you talk to most just people on the street who are talking about their arthritis, they're usually talking about osteoarthritis, which is extremely common and is essentially sort of over time and with age, degeneration of the joint itself. Usually the cartilage gets damaged and new bone starts to form to try to combat that damage. And again, as I said, it's very common, especially in the hands, the knees, the hips, and the spine. When you hear about people getting hip replacements and knee replacements, this is very often the reason. That's very different from when there's active inflammation in the joints, and that's what we call inflammatory arthritis, which also causes joint destruction, often can be much more severe joint destruction. But that destruction is a result of inflammation within the joint. And the most common inflammatory arthritis is gout, which we'll talk about in a lot of detail today. But the prototypical example of what we would consider an inflammatory arthritis as opposed to osteoarthritis is rheumatoid arthritis. And so here in this picture, you can see these joints over here are swollen, and it looks like the joints aren't sort of aligning in straight lines. This is because of the swelling over here. There's also swelling in these joints as well. And probably also the wrist looks swollen as well. Those are joints that are commonly affected by rheumatoid arthritis. And as you can see from this image, it does cause significant damage to the joints over time. The top images show osteoarthritis. So here is a normal joint, and you can see that over here, the two bones are much closer to each other. There's just more irregularity over here. It's much brighter. And those are all sort of things that we see in osteoarthritis. And then the same thing in the picture on the right, you can see there isn't a lot of swelling, but there's sort of extra bone that you can see in these joints. And osteoarthritis of the hands tends to affect the middle and the far joints of the fingers, tends not to affect these joints, unlike rheumatoid arthritis. And it also really likes the base of the thumbs. So getting back to gout, let's talk first about what actually causes gout. And the primary problem with gout is elevated uric acid, which is also known as urate. I apologize if I go back and forth a little bit in the terminology there. But elevated uric acid levels in the blood. And this chart that you can see on the right shows what happens when you monitor people with different levels of uric acid over time. You can see if you compare the purple line, which is essentially normal uric acid levels, less than 6, virtually none of those patients developed gout, very, very few. Whereas if you look at people with uric acid greater than 10, which is very high, and monitor them over time, these are people who initially started without gout, and you can see that within a few years, and if you follow up until 15 years, just about 50% of them have developed gout. So there's a clear relationship between uric acid and the development of gout. The next thing that happens, and usually takes about 10 years or so of the uric acid levels being elevated in the blood for this happens, but the uric acid then starts to deposit in joints and tissues. And when it does that, it does that because the amount of uric acid in the blood is above the level where it's actually soluble in the blood. So it tends to crystallize out of the blood and go into joints and soft tissues. And after years of that taking place, eventually the body reacts to the crystals being there. They become very irritating to the body, and that intense inflammatory reaction is what leads to gout. And this on the right is a depiction of what gout feels like. So I'm trying not to underestimate how painful this condition can really be. And the other thing I'd say about this image is it was from 1799, but we actually know that there have been descriptions of gout for thousands of years. This is a very old disease. And then over time, as that uric acid stays elevated, it starts to deposit more into soft tissues and develops more of those tophi, like I was describing earlier. And those tophi themselves can also really cause bony destruction and joint destruction. So next, I'd like to talk about who gets gout and whether or not it's common. It is actually very common, which comes as a surprise to a lot of the patients that I see with this. But about 5% of males in the US are affected and about 2.7% of females. And you can see here that there's a clear increase with age. So the red line here is the United States. And you can see that right around 50s to 60s, the prevalence of gout goes up significantly from about 3 to about 9%. So there's a relationship with age. There's also a relationship with sex. And you can also see that there's a geographic difference. So the USA curve is definitely higher than the other ones. And we think that that's probably from a combination of genetic factors and more so lifestyle factors, so relating to our diet in particular. So getting into those risk factors that I was just alluding to, yes, male and age are risk factors. Kidney disease is a very important risk factor for gout, and also really impacts the way we treat gout, which we'll talk about more in a little bit. Obesity is a very important risk factor for gout, and also related to obesity, the whole metabolic syndrome, which is the combination of obesity and high blood pressure and high blood sugars or diabetes and high cholesterol. Those conditions all sort of go together and predispose people affected by them to a number of conditions, and gout is one of them. So the whole metabolic syndrome is a risk factor for gout. Certain medications are risk factors for gout, in particular medications that are used to treat blood pressure and heart failure. And then genetics are very important in the development of gout. Some of the most severe gout cases that we see are actually related to genetic predisposition as opposed to some of these other lifestyle predisposing factors. And then diet, which we'll discuss a little bit more. So talking about diet, diet is an important trigger for flare, and there are a number of other triggers as well. When I'm talking about flares, I'm talking about those acute gout attacks that cause really painful inflammation. So in particular, the things that within diet can predispose people to flaring are red meat, shellfish, high fructose corn syrup, and alcohol. The reason for those, and this is not an exhaustive list, there are many others, but the reason for those is that they have a lot of purines, and what happens with purines in our body is that they get metabolized and eventually become uric acid. And that uric acid is what leads to gout. So that's the thought process there, and why eating these things can very often predispose people to flare. Medications, as I mentioned before, in particular diuretics, which are medications that make you pee excess fluid. And the reason those medications are usually prescribed is for heart failure or kidney disease or high blood pressure. Hospitalization itself is a significant risk factor for flaring, and very often people will be in the hospital for completely unrelated reasons and all of a sudden will develop a gout flare. We see that very frequently. And related to that, really any physiologic stress that someone is going through can predispose them to having a flare. Trauma is another flare, so very often people will sort of bump their foot and they'll develop really severe pain and swelling that's sort of out of proportion to what their trauma was, or it could have been a significant trauma, and we can see people flare in that setting. Then dehydration is another one. So in people with gout who are having frequent attacks, it's important to stay well hydrated. But then most importantly, flares can happen completely out of the blue and without any good reason. So I have had patients who are just so confused why they continue to have attacks. They're doing everything right. They're avoiding all of the right, all of the wrong foods, and they're eating all of the right foods, and they feel like they're doing everything right. But it's important to remember that this is a condition where diet is important, but sometimes gout is still just going to do what it's going to do. If people are getting flares frequently, then diet is very often just not enough to manage the condition. So let's talk about some of the symptoms of gout. I think I've mentioned the main one or multiple times already, and that's a rapid onset of severe pain and swelling. This is usually not something that comes on over the span of weeks. It's more like minutes to hours to a couple of days. And by then it will have reached its peak intensity and be very often debilitating. It can affect one or more joints. It can affect many, many joints at the same time, or it can be just one single joint. And there's usually redness and warmth associated with that as well. As I mentioned before, it can be quite debilitating. People can have a hard time walking as a result of that. But very importantly, if you just leave a gout flare alone and don't do anything, it will resolve on its own eventually. And that may take a week or two. Sometimes it can take much longer. But it will resolve. And I think that that's one of the reasons that gout is such a challenging condition to take care of, because very often people are feeling just fine between their flares and don't seek medical attention. So a lot of times you see people who are coming in fairly late after they've been suffering for a while, just because they feel well in between and they either never think to get it checked out, or they're doing well when they're seeing their doctor for other reasons. So it's just not high on people's priority list. And then I have shown now a number of pictures of this one joint being affected. And this joint has a very special relationship with gout. It's the most commonly affected joint in gout, especially earlier on as people develop gout. And when the base of the great toe is affected, we call that podagra. And that's something that we see that is very specific for gout and really makes us think about gout more than anything else. But that's not the only joint it can affect. It can affect many joints within the foot. And even in this picture, you can see that there's sort of swelling throughout the toes over here, and the rest of the foot looks much more swollen than the side. So even though this joint is affected, it looks like there's probably many other joints within the foot that are also affected in this person. So the feet, the ankles, and the knees are especially common to see. It can also affect the hands, the wrist. That's a little bit less common. But really, gout is one of these conditions that can do so many different things that we tend not to underestimate it. So like I mentioned, people can have absolutely no symptoms between flares. But over time, the flares do become more frequent. So initially when people get it, they might have a single flare, not have another flare again for another couple of years. And then they'll develop flares every few months, and then eventually it will become every few weeks, and even more common than that. And then in later stages, if this goes untreated for a very long time, people will start to develop more chronic, long-standing arthritis related to the gout. They start to develop tophi, and those tophi can lead, and the chronic inflammation within the joints can also lead to destruction of the joints and the bones. And here I just have a few more pictures of tophi in some of the common places where you see them. Ears are very often areas, and what I'm referring to is this and this are two little tophi. The elbow is the most common place where we tend to see this, and the tophi that I've shown you so far have been quite large, but very often they can be very, very small. And you may not even be able to see them, but you can feel them. And again, these are not painful. Very often, people don't even realize that they're there. And then it can affect the hands as well, and they can become quite large. And you can imagine that this would cause, even if it's not causing pain and it's not causing acute inflammation in the joints, you can imagine that that would cause some limitation in terms of how someone can use that joint. And if it does so in other joints, that can be quite limiting as well. So I'd like to now shift gears and talk about how we actually diagnose gout. The first thing we look for when we diagnose gout is the symptoms. Is someone having typical symptoms of gout? And what am I referring to with those? Do they have episodes of joint inflammation in one or more joints? It's very unusual, especially early on in the course, for someone to have joint inflammation that lasts a very long time. So we're really looking for these severe acute attacks. Does it involve the base of the great toe? Do they have podagra? If they do, then that's another thing that really makes us think about gout. And again, very painful. So people will often say that they can't wear their shoes when they're having an attack. They can't walk. And a classic description is when people will say the sheet, even just putting the sheet of the bed over their toe is too painful. They have to keep their toe uncovered at night because of the pain. We also look for, of course, elevated blood levels of uric acid, which the technical term for that is hyperuricemia. I should note that when someone's actually having a gout attack, their uric acid levels can be falsely low or normal. So it's really important, if that's the case, to check it again when a few weeks later, when someone is out of the flare and sort of feeling well from a joint perspective. But really, for someone to have gout, the primary problem is elevated blood levels of uric acid. So we really look for that. And if someone has any tophi, then that's also another thing that tells us pretty clearly that they have gout. But there are other things we can use to diagnose gout. These things are all things that can suggest gout, with the exception of tophi, which if someone has a tophus, then they by definition would have gout. But the rest of these can suggest gout, but they don't diagnose gout. The way we definitively diagnose gout is by actually looking for these urate crystals within joints. So the way we do this is we put a needle into a joint that's actively inflamed. You can't do this unless someone is actually having an attack. And we remove some of the fluid from the joint. That sounds like a really painful, terrible procedure. We do it very frequently. It's a very small procedure. It doesn't take any like anesthesia or anything along those lines. We use some cold spray or some local numbing medicine to help with the pain. And the whole procedure just takes a minute or two. It's very helpful to do this because we can see a few things. We look at the fluid under the microscope and we look for the crystals. That's one of the things that we do. And on the right side of this screen, you can see what the crystals actually look like. And if you can imagine these crystals in someone's joint, you can imagine how painful that could potentially be. And the reality is the body really doesn't like seeing all of those crystals there. And the immune system of the body reacts against those crystals, which is what leads to all of that inflammation. The picture that you're seeing here is under what's called a polarized light. So there's a polarizer that goes in one particular direction. And depending on, you can see that there are these, we call them needle-shaped crystals. All of these things that you're seeing, the needle-shaped crystals there, you can see that they're different colors. Some of them are the more sort of bluish greenish, and some of them are more yellowish orangish. And that's related to how they're aligning with the polarizer. So you can see the ones that are, the crystals that are more vertical are blue, and the ones that are more horizontal are orange or yellow. And that's how we identify the urate crystals. And when we see that in someone with a swollen, painful joint, then that tells us that they have gout. That's really the definitive way for us to be able to know. There's other things we can, the other information we can get by looking at this fluid under the microscope. We can get a sense of how inflamed the joint fluid is, which can be helpful in telling us a number of things. And then more importantly, you can imagine if someone comes in with a red hot swollen knee that's exceedingly, that's just extremely painful, you can imagine the first thing we would be worried about is that the knee is infected. And telling the difference between gout and infection can actually be surprisingly challenging. So by actually sampling the fluid, one of the other things we can do is make sure that we're not dealing with an infection, which would be a much more short-term serious problem that needs to be addressed. And then there are other ways we can diagnose gout, because we can't always analyze the joint fluid. That might be because either the joints that are involved are very, very small joints where we can't get much fluid out of them, or it could be that we're seeing someone when they're not actively flaring, so we're not able to sample any of that joint fluid. Or it could be that we tried to sample joint fluid and weren't able to get it, because that can happen as well. So in those cases, we can use other things to try to help us determine whether or not someone has gout. On the top, you'll see pictures of what's called an ultrasound. This is the same sort of machine that's used for sonograms for pregnant women. And what you're looking at here, this is a knee joint in one person in different views. And what we're looking at here is these two lines on either side of this over here. The black in between is where the actual joint space is. And that's where the joint fluid is. It's called the synovial fluid. And what you're looking at on either side is this bright white line. That's the two lines together are called the double contour sign. That's very suggestive of gout. Here you have, in the middle of the screen, you have images from what's called a dual energy CT. So this is a CT or a CAT scan, very similar to CAT scans that you would get done in other parts of the body, but it's done in a very special way where they can specifically look for evidence of crystals. And here what you can see is on the left side, you can see these little green dots on either side of the foot, one by the great toe, one by the little toe. And those are actually gout crystals. And then on the right side, you can also see that over here in the Achilles tendon. And then the last imaging modality that we also use to diagnose gout is X-rays. So very often when we get X-rays of the feet, for example, we can see irregularity in the bones. And here what you can see over here, and these over here, those are all sort of areas where gout has eroded away at bone. And when you look at those, you can kind of imagine they look like almost as if a rat took a bite out of the joints or the bones. And that's why we call those rat bite erosions. The appearance of those erosions is very, very suggestive of gout. So these are all other ways that we can signal that someone might have gout. Some of these are quite specific. So then I want to shift gears a little bit and talk about how to treat gout. And treating gout is more complicated than just taking one medication. So it's a little bit more involved than that. But like I mentioned before, we have really, really great treatments. So it kind of falls into different buckets. The first bucket is treating the acute gout attacks. And that's something that we have to do just to get someone to be able to function. But we have really good medications for that. The second approach that we take is we decrease the uric acid levels in the blood and in the total body. Like I mentioned before, it takes 10 years of elevated uric acid levels that's depositing all over the body for someone to then develop gout. So the time it takes to actually remove all of that uric acid from someone's body also takes time. It takes months to even years, depending on how much uric acid someone has in their body. But removing the uric acid in the short term does not actually prevent attacks. It over the long term will prevent attacks, but in the short term it does not, until that uric acid is actually out of the body. So then in the short term, we also use treatment to prevent future attacks. And we'll go into all of those in a little bit more detail now. So the first thing I'd like to discuss is how we treat the acute attacks. And we have a number of different options for this. One of the medications that we use for this is something called colchicine. It's used in very few other conditions. Gout is the most common condition where we use colchicine. And what it does is it prevents the cells that cause all that inflammation from actually eating the crystals and causing the inflammation. There are a few things to be cautious about with colchicine. In people with kidney disease or actually also liver disease, you need to reduce the dose or sometimes even avoid. And an important side effect to know about is diarrhea. So if you develop diarrhea while on colchicine, it might be an indication that the dose might be too high and might need to be reduced, or the colchicine might need to be stopped, depending on the severity. Another medication that we very frequently use, or group of medication, is nonsteroidal anti-inflammatory medications, or NSAIDs. And examples of this that I'm sure most of you have heard of include ibuprofen, which some of the trade names there are Advil and Motrin, or naproxen, like Aleve or Naprosyn. There are others. And these actually are extremely effective against gout. And they're available over the counter, which is nice. So they're available at higher doses through a prescription if you speak with your physician. You do need to avoid these medications if you have kidney disease, heart disease, high blood pressure, or if you are at risk for bleeding. There's also a risk that it can cause damage to the stomach lining. So if you have had prior inflammation in the stomach or bleeding from the stomach or intestines, or if you've had any ulcers in the past, those are reasons to really avoid these medications, not just for gout, but in general. But in people who are able to take them, these are really effective. I would mention in both of these, kidney disease is one of the things to be cautious about. But I also mentioned earlier that kidney disease is one of the main risk factors for gout. So that means that people with kidney disease who have gout have somewhat fewer options for how we can treat it. But we do have other options. The next option that we have is steroids. And these we use in many different conditions, but gout is certainly one of them. And they're safe to use in people with kidney disease. So we very often do that. There are many side effects to steroids, and those can include it affecting the mood. They can reduce the quality of sleep. They can increase blood sugars. They can increase blood pressure, increase the risk of infection. They can also worsen cataracts and glaucoma and bone health. So there are a lot of potential risks to steroids, which is why we try to use them as little as possible. But very often it's what we need to do to get the gout under control. And the steroids can either be taken by mouth or they can be done through the IV. But there's also the option of injecting the steroids directly into the joints. And the benefit of doing that is that there's little or less that gets into the rest of the body when you inject it straight into the joint. So you can overall expose someone to a smaller amount of steroid and still have a really good effect. The downside with this, of course, it is a procedure. It's a needle that goes into the joint, very similar to the process for taking fluid out. So the fact that it's a procedure is one of the downsides. The other downside to it is that we can only use so much of that. We can't inject every joint in the body, and we can't inject joints frequently. It's not safe to do that. So we really only do that if there are just a few joints involved, and they're joints that we actually can't inject. Other really important things to think about, ice is actually extremely helpful in gout. And very often people don't know that, and will actually place heat on their joints, and that can actually worsen it. But ice has been shown to be very effective. And then also just rest and elevation of the joints until the inflammation is better controlled can be helpful. And then the timing for how to treat acute attacks is extremely important. So colchicine in particular, but this is true for all of the medications, they work best if you start them early. Colchicine in particular really tends only to work if you use it in the first day or two of the flare. The longer the flare's been going on, the less likely it is to work. So for that reason, it's really important that you have a plan in place for when you're going to have attacks. Of course, if it's the first time you've ever had a gout attack, then you can't expect yourself to have a plan. But once someone has gout, they should anticipate that they might have flares, and they should have a plan in place for how to take care of those flares. There is no one plan that will work for everyone, so this is really something that you should speak with your provider about. So then what do you do if you do end up having an attack? The first thing you do, tell your doctor. And like I mentioned before, you should have a treatment plan in place. So start taking the medication that you discussed with your provider. And again, the sooner you start that treatment, the easier it is to treat, and the flare itself will last less time. So remember, I mentioned earlier that if you just leave a gout attack alone and let it do what it's going to do, it will resolve over time. But I mentioned that could take a week or two. And for such an excruciatingly painful condition, that feels like an eternity to very many people. So it's really important to treat this as soon as the symptoms start coming on. So that's the first bucket of treatment of gout, is we treat the acute attacks. But then the rest of what we do is to try to prevent them from happening. And the first way we do that is by lowering the body's uric acid. And we do that through a number of ways. The first is lifestyle. We always recommend people with gout follow a good diet, limit some of those purine containing foods, and weight loss in general for people who are overweight or obese can be helpful in preventing gout. Medications, though, are very often needed, usually needed in the management of gout. And these are medications that work to actually reduce the amount of uric acid in the body. The name for this class of medications is urate-lowering therapy. That's what we call it. And the goal with all of these approaches is to lower the uric acid to less than 6, sometimes even lower, depending on a number of other features. But the reason 6 is the magic number in gout is that the uric acid that's in blood is soluble until just over a level of 6. So if someone's uric acid is 7, then they're above where it's soluble, and that predisposes the uric acid from crystallizing out of the blood into the joints and causing the inflammation. That's why we try to get everyone's uric acid less than 6 and persistently less than 6. With good treatment and with getting the uric acid less than 6, we can eliminate gout flares completely. We can prevent them from coming on at all. So we really can do a wonderful job at treating this really painful condition, but it does take some effort and it takes some time. I mentioned diet. I have sort of on the left side things that are good, and on the right side things that are bad. So on the left side, we know that the Mediterranean diet is a very healthy diet that's been shown to be helpful in gout. Very similar, the DASH diet, which was designed for high blood pressure, has also been shown to be helpful in many other things, including gout. We know that cherry juice or cherry extract actually does lower uric acid levels in the blood. So that's something that people like to use as well. Vitamin C and low-fat dairy are good things to eat, just part of the normal healthy diet that can help prevent gout flares. And then avoiding the high purine foods, which I kind of went over earlier, the alcohol, red meat, high fructose corn syrup, so for example, non-diet sodas, shellfish, and high-fat dairy. However, we recommend dietary changes for everyone with gout, and being aware of all of these things and that they can trigger flares and that they can elevate the uric acid in the blood. But in the vast majority of cases, it's not enough. And the vast majority of people do end up needing to be on medication lower the uric acid and effectively prevent flares from coming on. So that gets us into what medications we use. By far the most common one is something called allopurinol, which works by preventing the formation of uric acid in the body. There's a very wide dose range that's available, anywhere from 50 to 900 milligrams per day. But there's an important side effect of, it's a very rare side effect, but important, which is called allopurinol hypersensitivity. And what that causes is a severe rash, and also can cause internal organ damage, like it can affect the liver or the kidneys. While it is very rare, it is an important side effect to know about. So that's one of the reasons that we start at a low dose and then we increase very slowly. The way we do that is we start at a low dose, and you need to discuss what that dose exactly is different for everyone. So you'll need to discuss that with your doctor. But it usually involves getting blood work checked every 2 to 4 weeks until we can get to a dose that effectively gets the uric acid less than 6. So that is a lot of blood work, but in most people, if we're able to keep up with that blood work, we can get the uric acid down to a level less than 6 within just a few months. And then the blood work can be much more infrequent. And once we do that, then we can be confident that flares aren't going to happen anymore. There are other medications we use in addition to allopurinol, but allopurinol is much more commonly used than all of the others. Some of the other ones you might hear about are febuxostat, probenecid, and pegloticase. I won't go into much detail there because I think that's a little bit beyond the scope of what you're most commonly going to be seeing with gout. And most people really are able to just get away with allopurinol alone. But there's a very important risk of any of these options, which is that early on, the urate-lowering therapy medications can actually precipitate attacks, which seems counterintuitive. It seems if we're decreasing the uric acid, why wouldn't we be preventing attacks? The reality is any changes in the body's uric acid levels can predispose people to attacks. So someone has to have too much uric acid in their blood, in their body, to have attacks, but any fluctuations up or down can precipitate some of those attacks. So early on, while we're still getting the uric acid under control, people can have increased flares. And we'll get back to that in just a second. So when do you take the urate-lowering therapy or the allopurinol? You take it every day as prescribed. You don't stop during flares. You don't just take it during flares. You should take it all the time. And the reason, part of that reason, is that starting and stopping can actually lead to flares. And the whole point of these medications is that they work over a very long time to lower the body's uric acid and keep it low. And how long do we treat with these medications? In most cases, we treat indefinitely, because what we've found is that if you stop the medication, the urate starts to build up again, and it's kind of only a matter of time until people start to flare again. Of course, this is a case-by-case decision, and sometimes we make different decisions, but this is what we do in the vast majority of cases. So it's really important to understand what urate-lowering therapy is and to be really good about taking that every day, because that's the way that we can really keep gout at bay. But like I mentioned, taking it, at least in the short term, can predispose people to more flares, and it can take months to even years to completely get their uric acid under control to a point where we know that flares aren't going to happen again. So the way we combat that is we use medications to actually prevent flares. So like I mentioned, urate-lowering therapy can cause flares because of those sudden fluctuations in the urate. And it can take actually some time after we get to the goal uric acid for all of those uric acid crystals to dissolve. And flares can still happen in that time. So for that reason, we use medications that you take on a daily basis or every other day, depending on the medication. And you continue to take that until the uric acid is really stable and we're not anticipating any changes. and we see that flares aren't happening anymore. And the medications that we use for those are colchicine and NSAIDs, kind of similar to the medications that we use to treat the flares. They're taken on a regular basis at different doses to prevent the flares. And the specifics are of the dosing and everything are things that you'll need to discuss with your doctor. So let's go back for a second and say, what do you do if you have gout? What's next? So the first thing to think about is your diet and lifestyle. So think about the Mediterranean diet, think about the DASH diet, avoid alcohol and shellfish, high fructose corn syrup. Have a plan for what to do if you have an attack, and have this ready to take at the first sign of an attack rather than waiting for it to become debilitating. Take your urate-lowering therapy and continue to get your blood work checked until you get to a uric acid less than 6, and take it consistently unless your doctor tells you otherwise. And then usually also taking medication to prevent flares, though eventually that is something that we'd be able to stop once the uric acid is under control. And then just very briefly, I want to touch on something called pseudogout, which sounds like gout, but is not gout. This is another related condition that's also, it also causes joint inflammation, also related to crystals, but it's a different type of crystal. Instead of a urate crystal, it's a calcium crystal. And specifically calcium pyrophosphate is what it's called. It can look very similar to gout, but it usually affects different joints. So in particular, while gout likes the legs, pseudogout likes the arms. So very often in the hands, in the wrists, in the elbows, and the shoulders. But both gout and pseudogout love the knees. So when we see this in the knee, it really could be either, and the way we differentiate is by looking at the crystals under the microscope. And something that you can see in people with pseudogout is actually calcification of some of their cartilage within their joints. So here you can see this is someone's knee. You can see over here this white line that's not quite in this bone, not quite in this bone, that's kind of inside the cartilage of the knee. That's calcification. And we see that very often in people who have pseudogout. This same process you can see over here in someone's wrist. These are bony changes that we can see in pseudogout. And then you can see those same calcifications on ultrasound. And note that this looks very different to what we saw earlier, where there was the two very bright lines here and here, where you're not seeing that anymore. And then, so these are a couple more pictures of pseudogout. So on the left side, you can see what the crystals look like. And you can see here, this is a blue crystal. This is kind of bluish, but the shape is different from what we saw before. And just as a point of reference, this is what we saw before. The two crystals look quite different from each other. So we're able to tell the difference between them under the microscope. And I also mentioned, when you look at this under the microscope, there are crystals everywhere. Over here, you can see that there are just a few crystals over here. And very often, it can actually be very hard to find these crystals. So sometimes we'll even look at fluid under the microscope and not find any crystals. And we'll need to do the same thing multiple times to finally find the crystals of pseudogout. And like I mentioned before, it tends to affect the hands. And unlike gout, it can cause a more long-standing, or it more often causes a more long-standing arthritis. And these hands actually look very similar to the hands that I showed you earlier with rheumatoid arthritis, with swelling right around here and the bones not aligning straight. So that's pseudogout. And the way we treat that is with many of the same medications as we use for gout, but they are different in that way. So the take-home messages I would go over one last time. Gout is common and extremely painful, and it's an inflammatory arthritis. It's caused by uric acid crystals in the joints and soft tissues. It's chronic, and it warrants long-term treatment. It's not something that you can treat and then let go and not think about again. Dietary changes are very important in gout, but they're usually not enough in completely managing gout. And then the management also includes a combination of treating the acute attacks, lowering the uric acid in the blood, and taking medication to prevent future flares. Here are some resources I would recommend for patients who want more information about gout. There's the American College of Rheumatology, the Arthritis Foundation, and Creaky Joints, all very credible sources. And I appreciate your time and attention, and I'm happy to answer any questions.
Dr. Katz, that was fantastic.
Thank you.
To the participants, I'm Dr. Marcy Bolster. I'm one of the rheumatologists at MGH, and I work closely with Dr. Katz in his fellowship training. And Dr. Katz provided such an informative talk about gout. And I will say that there are several questions in the chat. And if it's okay, I'll read the questions to Dr. Katz and ask him to answer them. And if I can add anything, I'm happy to. But I look forward to Dr. Katz's response to the questions. So let's ask this question. Are there alternative therapies to control gout? For instance, is there a special exercise routine?
So exercise is a very important thing for just keeping joints healthy in general. And I think exercise is extremely important, particularly with weight loss as well, which is part of the management of gout. But unfortunately, exercise alone is just not going to lower the uric acid by itself. And it's really not an alternative to some of these, the medications that we discussed.
Okay. Someone asked if maybe you could just repeat why some people have an elevated uric acid in the blood.
Oh, sure. So there are many reasons that someone might have elevated uric acid levels. Sometimes there's no good reason. Sometimes it's genetic. Sometimes it's the medications that they're on. And sometimes it's related to other medical problems. Like I mentioned earlier, the metabolic syndrome with obesity and high blood pressure. In particular, kidney disease can really elevate the uric acid. So there are many reasons that someone might have an elevated uric acid, or it could be for no reason that we're able to clearly identify.
And I would just add that some people handle uric acid differently at the level of the kidneys. And so some people maybe make extra uric acid and it's just harder for the kidneys to get rid of all the excess. And then other people may not excrete as much uric acid at the level of the kidneys. And that's just kind of the way they're born. May have to do with genetics, I guess. But so there are lots of different ways that people can develop the propensity to gout. And that's why sometimes we see gout in very young people, particularly in men in their 20s or 30s. And we know that hormones like estrogen help the body to get rid of uric acid. So we don't tend to see gout in women who are premenopausal. So there are just so many factors at play. In mentioning genetics, here's a question, perfect segue. What are the chances of having gout if one of your parents was diagnosed in their early 50s?
Oh, that's a great question. I don't have a number off the top of my head. I would say the chances are higher than other people who don't have a family history, but I can't give you an exact percentage.
I agree. I think it would be hard to know. I don't think that knowing that a parent had gout doesn't mean that the child will have gout, because there's so many different ways that people can be predisposed to gout. But I agree with what Dr. Katz said. And then someone asks, can you speak to prednisone? I think, Dr. Katz, you mentioned steroids, and maybe earlier on you called it steroids, but somebody asked, can you speak to prednisone as well as diclofenac gel for treatment?
Yes, absolutely. And my apologies, I should have written prednisone as in the steroid section. Prednisone is a steroid, and it's the most common steroid that we use. There are other options, but prednisone is the most common one that we use. It's an oral tablet steroid that we use very, very frequently in the management of gout. And then you also mentioned diclofenac. There's diclofenac pills, which just like ibuprofen and naproxen is another one of those non-steroidal anti-inflammatory drugs. that can that can be very effective in treating gout as well. The diclofenac gel has not been studied in gout to my knowledge, but anecdotally, there are people that have said that it can be very helpful in some of the smaller joints where it might be able to penetrate into the joint a little bit better. But it's a nice way to be able to take a non-steroidal anti-inflammatory drug without some of those systemic side effects.
Given that it takes 10 years of an elevated serum uric acid to develop gout, is there an early or recommended screening test to try to head it off?
That's a wonderful question. Thank you for asking that. The reality is we haven't found that it's actually helpful to treat elevated uric acid in people who don't have gout. So if you treat just the elevated blood test alone, you're kind of you're providing someone with a medication that has side effects, right? Every medication has side effects without any clear benefit, because there are no flares to prevent. And if you think back to the slide that I showed earlier with tracking people who develop gout over time, even in people with a very elevated uric acid of greater than 10, following those people for 15 years, only about 50% of them developed gout. So that's a lot, but that also means that 50% didn't. So that could, if all of those people had been started on a medication, 50% of them will have been taking a medication that they didn't need for 15 years. So we actually, for that reason, we don't screen, because we wouldn't start treating unless someone actually has gout flares.
Yep, great question, great answer. Do patients commonly stay on allopurinol and colchicine long-term, or eventually just allopurinol?
So in most cases, you would continue taking the allopurinol long-term. And then once the uric acid is less than 6 and remains less than 6, and the person is not having flares, then we would usually stop the colchicine and only restart it if they're having flares again, in which case we need to sort of evaluate why the flares are happening.
If you have gout, are you destined for complications like kidney disease?
That's a wonderful question. It stems from the fact that uric acid itself, in addition to leading to gout, the other thing that it can do is it can lead to kidney stones, and it can lead to kidney disease. So the two are related to each other. Gout itself doesn't cause the kidney disease. It's uric acid can cause kidney disease. But the answer to the question is no. Just because you have gout does not mean that you're going to develop kidney disease. But people with gout, because of the relationship between gout and kidney disease, it's common for us to see people with kidney disease who develop gout, or people with gout who develop kidney disease.
And then maybe this is the last question. I think, Sam, we need to wind up at 1. And there are more questions. Some of the questions are a little bit specific to certain medical conditions. So I'm going to just try to choose a last question that is more, I think, addresses a lot of people's concerns. If prednisone doesn't completely cure a flare, then is it gout?
Oh, that's such a wonderful question.
Might take more than a minute, but do your best.
Yeah, we see that a lot actually in rheumatology, and that could be a number of things. One, yes, it is possible that it's not gout, and one example is if there's gout and there's osteoarthritis in the same joint. Again, the osteoarthritis is the arthritis that's more related to wear and tear degeneration of the cartilage in the joint. That does not usually respond to prednisone. So it's possible that the prednisone treats someone's gout, but they still have pain related to something else. The other possibility is that sometimes gout can be quite stubborn, and it can be very difficult to get under control. So usually it responds to doses of prednisone around 40 milligrams, but sometimes we have to use more. So that's where it really is a case-by-case basis, and you have to see how are things doing, what's better, what's worse, and is there anything new that came up that would explain why things aren't great on the prednisone.
I would just add, sometimes, as Dr. Katz said, we need a higher dose, or sometimes we just need a more prolonged course of the prednisone to try to get it under control. People are just so different. Well, we're just past the hour. So Dr. Katz, thank you so much for a great talk. And Amy, thank you very much for the opportunity to speak to the audience that we've had today, which I assume is there because they're sending questions even though we can't see them. We hope that it's been an informative hour for you.
Thank you so much, Dr. Bolster. And as I mentioned earlier on today's session, if you want to view the recording of today's program, feel free to visit the Blum Center website. It'll be made available probably in about a couple of weeks, but you can visit our website at massgeneral.org/Blum-Center and be posted there. Thank you so much, everyone, for joining us today. Have a lovely rest of the day.
Thanks.
All right, thank you.